barrier disruption. So the blood-brain barrier, as I'm sure everybody knows, is that junction between the bloodstream and the cerebral spinal fluid, the fluid that bathes the brain and spinal cord, the central nervous system. What folks may not know is that, like what's so special about the blood-brain barrier? Like, how does that work exactly? And just to give a little bit of insight there. So my understanding of it is that our all of our endothelial cells, so the cells that line our blood vessels, they're connected by these proteins that form what are called gap junction proteins, and they, of course, keep things pretty tight together because otherwise we'd just be oozing blood into our insides through our arteries and veins and would be a big mess and would not be good, would not survive very long. Um, Whereas at the blood-brain barrier, and I'm blanking on the exact numbers here, but I think it's something like 10 to 30 times more. The junctions are 10 to 30 times more tight or something like that. It's like a markedly greater amount of tightness between those blood vessels. So it's much, much harder for things to get in and out of the cerebral spinal fluid, which makes sense because the brain is very important and very sensitive to toxins and various things like that. So we, want to make sure that it's not getting easily exposed to infections and metabolic waste products and impurities from the environment and things like that. Unfortunately, when there is nervous system when there are neuroinflammatory conditions, neurodegenerative conditions, which are always neuroinflammatory in nature, or there's autoimmune conditions affecting the brain, then the blood-brain barrier can get disrupted and we can develop what they sometimes refer to as like a leaky blood-brain barrier, just like people talk about leaky gut syndrome. People talk about leaky brain syndrome or leaky blood-brain barrier. So as we can see here with this patient, really nothing eventful coming up at all with his blood-brain barrier, which is great. Now, again, with this patient, again, history of Parkinson's, was already doing quite a bit better. Like he'd been on some supplements, some dietary changes, was working with some neurofeedback, so was already doing quite a bit better before we did this test. This was more of like a check-in test. And so would have been interesting to have a baseline before we started all of that, but anyways, this is the information we had. And maybe it looked fine in the first place, hard to say. But as we can see there's 4 different markers looking at blood-brain barrier disruption. The next section here is looking at optical and autonomic nervous system disorders. So another 4 antigens there. So as we can see there, the anti-aquaporin 4, which are water channels, to my understanding, my recollection, the most prevalent water channels in the brain. So those can be significantly impaired by neurodegenerative and neuroinflammatory processes. As we can see there is IgG, IgA is greater than 30, which is the highest result you can see. If you recall from the first page, or further up this first page, the reference range says anything above 20 is considered a risk. And so we're really paying attention to anything that's above a 20. Greater than 30 is the highest number that we can see. So whether a patient's actual result was 31, 40, 50, 60, 80, all that the assay can report is greater than 30. So we don't have a specific number there. We just know it's very, very high. And we can also see there that the IgM antibody level is at 13.7. So not only does it seem that the fire was, a fire had been set in the forest, but it looks like there's still some active forest fire setting as well. So this would be a good example of where, my clinical approach would be to say, like, okay, we definitely want to reduce the inflammation. We definitely want to work with some immunomodulators, but we probably want to be a bit more aggressive in terms of saying, like, well, let's really make sure we're getting on top of those immunomodulators because we know that there's some active fire setting happening. But then also looking to see, is there some trigger for this that hasn't been addressed yet? So are we missing the mold exposure? Are we missing some underlying infection? Are we missing food sensitivity? Is there like a leaky gut syndrome issue that's causing more endotoxin to release into the bloodstream, and that's maybe contributing to this. So it would usually mean we want to do a bit more digging, see what's going on. Now, a 13.7 isn't super high, and again, without the privilege or benefit of having a baseline result, then we really don't know what that level looked like before he started treatment. So it may be that had we done this test a few months earlier, maybe his level was at an 18 and now it's down to a 13.7. Maybe it was at a 22 and now it's down to a 13.7. Maybe it was at a 13.7 and it's still a 13.7. We really don't know. So when we eventually do a follow-up on this, then we'll have more insight. All right. And then the next section here is looking at peripheral neuropathy. So as I mentioned at the start of the episode, most of these most of these markers are specifically looking at the central nervous system. However, there are some that look at the peripheral nerves, so those spinal nerves. So if I had a patient who had, say, otherwise unexplained peripheral neuropathy. So, they're non-diabetic, they didn't have an injury. There's really no obvious reason why they're maybe having burning symptoms or like they didn't have like a, spinal cord injury or like a disc herniation. Like maybe they have, weakness and tingling in their lower extremities and, everything's been ruled out, but we can't figure out why this is happening. These would be useful markers to look at because maybe there's some peripheral neuropathy going on. Now, this particular patient, he doesn't have any really obvious peripheral neuropathy symptoms. Now, I mean, he is an older gentleman, um, you know, so maybe if he was to really put on his thinking cap and say like, oh yeah, like maybe I don't have like, quite as much sensation in my feet as I did once upon a time, or, maybe, as folks get a bit older, oftentimes they'll feel a bit more, stiff, when they first wake up in the morning or just not quite as limber, maybe that's some reflection of some underlying peripheral neuropathy going on, but levels really aren't looking bad. Now, it is, just worth paying attention to, in my opinion, that, that anti-GM1 is at 14.6 for the IgG-IgA. So we know like some fires were set, but there doesn't seem to be active fires happening with the anti-GM1 antibody specifically. But then that anti-GM2, while the IgG-IgA looks good, the IgM is a very, very mild positive. So, something where he's not having any obvious peripheral neuropathy symptoms. I'm not getting into, we're not like specifically targeting that, saying like, oh my gosh, you should be on, like high dose R plus alpha lipoic acid and acetyl L-carnitine, and high dose methylcobalamin, like active form of vitamin B12, and all the things that we would normally throw into the mix to help with peripheral neuropathy. But we'll definitely be keeping an eye on these levels with a follow-up test, and hopefully with I recommended immunomodulation for this patient, like immunomodulators and anti-inflammatories for this patient, based on these results. And so when we do a follow-up, a few months down the road, then we'll see how those levels are looking. And as I'm saying this out loud, I'm thinking I'll probably do a follow-up podcast episode, at least some follow-up social media videos, going over, how do the follow-up results look like, so we can take a look at those, because that might be of interest. But overall, does not look like there's a ton of peripheral neuropathy going on. So the next section here, looking at markers for neuromuscular disorders. So this gets really interesting to me, anyways. Maybe to others. I hope there's some interest, anyways. Where when patients have Parkinson's symptoms, of course, there's a lot of issues with their movement, right? There's tremors. There's their gait is affected. Sometimes their ability to their speech is affected. Their balance is affected. So we think, well, yeah, that sounds neuromuscular, and yet we look at this patient and we see that like, nope, that's all. It really looks very uneventful. Some very, very mild positives there, but really nothing major coming up. And then of course, when we know it's Parkinson's, well, of course it's a dopamine related issue, and the loss of dopaminergic neurons is what's going to drive those symptoms. We can see on a neuromuscular level, everything is looking really good. Now, the next patient's results that we'll look at here, this patient actually has some notable levels of, I believe it was the anti-voltage gated calcium channels. Might be potassium. I'm pretty sure it was calcium. Maybe it was potassium. I can't remember now. Anyways, with this other patient who has an MS, not this patient, but the next report we'll look at, is a patient with an MS diagnosis and has a lot of neuromuscular symptoms that are just really, unfortunately, not responding to treatment. And we saw one of those channels lit up like a Christmas tree. I think it was the potassium, now that I think of it. So that was, seemed to be very, very relevant to his case. But with this patient, things are looking good. The next section here is looking at particular markers of brain autoimmunity. So this, as we can see there, so looking at cerebellum, like anti-cerebellum antibodies, cerebellum being part of like in the back of the brain, which relates to the area that relates to your balance, or our balance. It's also involved in a lot of other processes too. There was a really great podcast interview that I listened to. There's this doctor down in the States. She works out of Daniel Amen's clinic, I believe, like the Amen Clinic, where they do a lot of brain scanning, brain mapping, like SPECT scanning, things like that. Her name's Dr. Ebony Cornish. I've heard her speak about a few different topics. She's quite varied in her topics that she talks about. She talks about I've heard her talk about the cerebellum now, and then also she talks about Morgellons disease, which is quite a rare condition, but like when you have it, like dear God, you really want to make sure you have a clinician who knows about it because it's a really debilitating, challenging condition. And so, anyways, Dr. Cornish was talking about how the cerebellum is actually involved in so much more than just balance. It's involved in a lot of different, like emotional processing. It's involved in different, higher level nervous system function. Like so, of course, every region of the brain is important, and there's interplay between, all the different regions, to a large extent. The cerebellum is just more than just for balance. Anti-Purkinje cells, which is also related to cerebellar function, anti-Yo antibodies, which, if memory serves, are also related to cerebellar function. Then the anti-amyloid beta markers that relates to beta amyloid